long name for it. And the purpose of this series was really to provide an opportunity for us to hear from researchers who are conducting research outside of the traditional healthcare settings, and to really understand what are some of the areas that we can have more research, and how to work together and collaborate on future projects. And as Rochelle said, this is a series that's funded by our UCSF CFAR Boost Award, so thank you very much to them. And I'm so incredibly honored to introduce Dr. Jessica Haberer, who I look up to so much, and is an incredible researcher in the field of HIV. Dr. Haberer is a professor of medicine, an internist at the Massachusetts General Hospital, and a professor at Harvard Medical School. She's been working in global health and studying adherence to antiretroviral medications for treatment and prevention of HIV infection since early 2000s. And her research focuses on real-time adherence monitoring and interventions. And she has many projects in Uganda, Kenya, and South Africa. So without further ado, I'll turn it over to Dr. Jessica Haberer.
Great, thank you guys so much for the thank you so much for the opportunity to join you all today. I trained at UCSF, so it's always a little bit like coming home to do things with you all, even if I'm sitting in Boston at the moment. I was there recently, so I'm sorry not to be doing this in person. But thank you all for joining today. So, all right, so I have about, I think, 35-40 minutes of presentation, and then hopefully we'll be able to have a nice discussion afterwards. Okay, so I'm going to be talking to you about a project called PrEP My Way. As you can see on the screen here, this is a peer-supported, community-based delivery of PrEP and other sexual health services. And it's designed for young women in Kenya primarily, although we're hoping this is a model that can be extended beyond where it was initially developed. And I think it's in line with the series that you have here of thinking about different ways of providing care that may be more attuned to the needs of the communities that we're trying to serve. So these are my disclosures. I don't think there's anything of a conflict here, but I have been fortunate to be funded. So I'll start with a very brief background, because I imagine most of you are pretty familiar with some of the challenges around providing HIV-related care in the world. But I want to focus today mostly on adolescent girls and young women who face particular barriers to using PrEP and to being able to maintain adherence and persistence over time. I think we've seen in a lot of studies that there's great interest in PrEP, but it often kind of tails off pretty quickly. And that persistence in a PrEP program really has been fairly short-lived for many people. And sometimes that's appropriate because PrEP may not be right for everybody, but other times it's because of barriers beyond someone's interest and deciding, maybe PrEP is not for them. And I was fortunate to be part of the IMPEA study that we ran in 2016 through 2020. And this was a study, I'll talk about it a little bit more in a couple of slides, but this is in partnership with Elizabeth Bukusi and others in Kisumu, Kenya. But we saw this pattern of young women being very interested in taking PrEP and then just kind of tailing off again over time, as has been seen in lots of other studies. I mentioned here HPTN-082, the POWER study, which some of you guys may have already heard of. You can see some citations at the bottom. But this is something that we've seen over and over again. And so with the My Way intervention, and I will go back and forth between PrEP My Way and My Way as the name of the intervention, but I'll explain that as we go too. But this intervention is really focused on the persistence piece of it. This is the data that you can see in the figure here from the IMPEA study. And it looks like somehow the graph got corrupted. So I apologize, I don't know what happened there. But this is PrEP adherence on the y-axis and time of follow-up on the x-axis. And in the IMPEA study, we enrolled about 350 women between the ages of 18 and 24 and followed them for a couple of years. We did have a trial component to the study where we were looking at SMS reminders as a way to boost adherence, which did not work. unfortunately. And you can see with the two lines here, the groups with and without adherence reminders being very, very similar. And adherence measured here is with the Wise Pill device, so an electronic monitor. Let me just move my screen around here for a second. Okay. And so what we're trying to do with the My Way intervention is look at this potential missed opportunity. So if we see women here at month 1, these are the folks who stuck around after initially getting a prescription. And for those who've come back for that first month prescription, we can probably say that PrEP may be something that they're interested in continuing. But we can see again this drop off, and we're targeting this difference here between the 20% that stay on PrEP and maybe the 65-70% that showed up at that 1 month visit. Say, like, is there something we can do to overcome those barriers? So we approached this intervention through social cognitive theory. And I imagine you've talked about this in other webinars, but having this underlying theory behind the intervention development, I think is helpful in trying to figure out what exactly we're doing with this intervention, and is it meeting the needs of the population we're trying to serve. So with social cognitive theory, you can think of two kind of these pink circles here as factors that we want to address so that we can influence the behavior, which is the green circle. And so with the cognitive factors, we want, these were things that we identified in the PS study, and others have seen this in other settings as well. But there are some issues like low empowerment, like feeling able to take PrEP, and we are co-packaging a lot of other sexual health services with PrEP in this intervention, but definitely concerned about low empowerment, maybe low motivation with a lot of competing priorities, maybe not knowing enough about PrEP or other sexual health services, especially with the young population, and maybe some difficulty taking pills on a daily basis. Thinking about the environmental factors, are there structural barriers that are getting in the way? Convenience is important, especially with young populations that can have these competing priorities, and the harder we make it for people to engage in our healthcare system, the less they will engage. So can we do something to make things easier for them around time constraints, transportation difficulties? And stigma is a big issue in coming into the more brick and mortar kind of traditional healthcare system, as I'm sure you've discussed previously. So our goal is to overcome these cognitive and environmental barriers so that the behavior of adherence and persistence can be achieved if that's something that makes sense for the participants in our studies, and ultimately just people in the community. And I mentioned this idea of prevention effective adherence, meaning that with PrEP and with any other kind of prevention, people don't have to take it forever. In fact, it's very unlikely that they would need or want to take it forever. So can we align the use of a prevention tool with the times that people actually need and want to use it? And that's what we term as prevention effective adherence. So that would be adherence in the moment that we're talking about. And then persistence is how they are able to adhere to PrEP and other services over time. So with the My Way intervention, our hypothesis is that a novel, supportive, community-based and led delivery system that offers privacy and convenience could improve PrEP uptake and I should have said here, persistence when needed and desired. So that's our overall goal with the intervention. So how did we go about developing this intervention? We used a client-centered approach to design it. And we did come in with some preconceived notions of what it was we were trying to do. So we had this idea that if we could put everything together in a kit with good instructional materials, with a peer-based system that included some type of phone communication and delivery of this kit, that this could help overcome all those barriers I just mentioned. And so this is a photo here where you can see, this is during like the pandemic, so you'll see lots of masks in some of these photos. But this person here on the left is one of our design leads from a firm called ARC that's based in Nairobi that led a lot of this human-centered design work. And then there are members of our team and also some of the participants who agreed to have their photos taken. But this was how the intervention was developed. So we came to the community after having worked on prior studies in the area and asked them, with this idea in mind, with these identified barriers, do you think we can put these tools together in a way that will really help achieve, the stated goals? So it was honestly really fun to work with this design firm. I don't know if any of you have done this kind of thing before. But certainly in San Francisco, there are lots of groups like IDEO who do this kind of human-centered design, and they put post-it notes everywhere, and people like play these games to kind of get the community engaged. But it's a really fun way to think about design, and I've really just enjoyed the process so much, and have gone on to work with this group in other studies and projects as well. But this is just sort of their approach to design, which they call simplicated. Again, they have lots of funny terms and cool ways of looking at problems that I think as scientists we don't always appreciate. So it's simple, but dealing with a complicated issue. So starting with the challenge and then creating possibilities. So the initial interviews were all about creating possibilities of what could we do in this context that we presented to the community. And then how do we make choices and bring that wide possibility list down to something that is considered clear and addressing the problems that we've identified and the outcomes that we're trying to achieve. And then going back after the interviews to more of a focus group approach and a workshop kind of environment that was designed to address ideation and design direction. And then again, narrowing that in once we had considered all the possible approaches to our desired outcome. And I won't go into great detail as to how that all took place, but one thing I wanted to highlight was the use of personas that we used in our workshops and some of the prototyping that went into the intervention development. So again, we identified challenges, ideated solutions, and then we really just explored needs. And we started off with some of these personas. So this one is about Alice Njiri. She's not a real person. This is all sort of made up. But we had several of these personas that helped make the design process more tangible. So we created profiles, like with Alice here as being a 23-year-old young woman, dropped out of school, got married, had a child, found out her husband was living with HIV, and just those are the kind of challenges that she was addressing, and she's in our target age group. But there are others, who may be in school, they may be living with their parents, other factors that really could influence what it's like to deliver something into the community, and what kinds of environments might the peers encounter, what are the needs of the young women that they would be working with. So this was just one of the approaches we used to try and stimulate that discussion. And we started off initially just with young women, but we learned over the course of doing this that young women don't live in isolation. So we brought in their partners if they wanted to come in, or other young men who are kind of in that same demographic. We brought in some community health workers to get their experience. Other, nurses, people who might be involved in delivering these kinds of services. So it really organically grew to encapsulate all of the different elements that seem to have relevance through this process. So it's very much a holistic approach, as you can see here, with a kind of socio-ecological model, where we were considering communication, service, product, and organization, and how all of that influences the customer. Again, this is the design approach that ARC used. And they have these cool, like models and thinking about defensibility for all of the different problems that could come up, or challenges that could come up in each of these different layers. And just to give you a little bit more of a sense as to what that looked like, when thinking about the organization, we explored different partnership models, and I'll kind of touch on some of these elements as we go. But we also considered a wide range of different products. I mentioned those kind of like expanding and contracting, brackets from our simplicated approach. And so with the product, we thought about a PrEP kit. We thought about having different types of PrEP kits, maybe one for teenagers, maybe one for couples. We didn't actually end up using all of these ideas, at least not yet. But this was part of the process I wanted to share with you. And then there were different services that we explored using within the intervention. So video, pictorial instructions, A lot of this was inspired by some work by Aaron Siegler, who is one of the co-investigators on this project, and he's done similar work in the U.S. with MSM on delivery of PrEP to homes. But it's a very different context than working in Kenya and with young women. We also talked a lot about different approaches to counseling. What would the peers talk about? Would it be focused on side effects? How would we manage their level of knowledge? Just a lot of other options that we could include as part of the service. And then with communication, how do we make the community aware of what we're doing? How much education do we provide at this point? Thinking about everything from community talks to like road shows and so forth, and just thinking about when and how that would all fit into this intervention. And then we also talked about service delivery flow. And so I won't go through every step here, but we talked about what it would be like to receive care in the health center, but again, thinking about moving out of that environment and going to maybe a safe space or some other place that users for PrEP and the overall package would want to receive those services. So then we're moving around to like, where's the peer? How is she going to engage? What's that flow going to look like? Do people go back to the health center? Do they, how often do they need to do that? Do they stay in the community? Do they want to end up in another type of facility from where they started? So we thought about all of these different kind of service flow models. And then finally, I want to mention the role of the peer. So when we're not delivering care with a nurse or a doctor in the clinic and relying on our peers, what do we want to ask of them? What is fair? What is safe? What is expected in the community? Dealing with stigma, for instance, was a big topic. Our peers for this intervention are between 18 and 30. So that they can be, have a fairly easy time relating to their clients. But that also means that they may not have that much experience or training. So what do we really need to provide to them so that they feel comfortable, and making sure that we're addressing that, like one of the major barriers, which is, stigma in coming into the clinic. So we talked a lot about what is the role of the peer and how she's going to be very, very central to this intervention. So this is the PrEP My Way kit that we ended up with, and our design team had a lot of fun with colors and packages. And I think in the end, the final product was really well received, and you'll see some of the data in a moment. But they tried to make this fun, like this box is happy to see you, just little things like that are hopefully engaging, especially to a young audience. So this kit is something that started in the clinic. So when we envisioned the intervention, it was not starting PrEP or providing any of these other services initially in the community. Part of that was because of regulatory requirements. That's not quite where things are yet with the Ministry of Health in Kenya. But in other settings, it might be, and it might be in the future. But our model was, again, focused on persistence. So building off of the existing structures and thinking about how we continue that into the future if PrEP is still a good choice for the clients. So this kit has HIV self-testing, either oral or finger prick, has PrEP. Obviously, that's part of what we're trying to do here. But we also recognize that PrEP is not the only thing that young women may want. And so we included STI self-sampling. Ideally, we would have everything in this kit be point of care. We're not quite there yet with STI testing, although I think we're very close. I've seen a couple of really good prototypes out there. So maybe within a couple of years, we'll be able to do that. But for now, we used just vaginal swabs that could be self-administered and then brought back to our site for testing with Cepheid. We have point of care pregnancy tests and then choice of contraception. Any of the following, obviously only one hormonal method, but people could choose condoms, they could get oral pills, or self-injection medroxyprogesterone, also known as Cyanopress, which is a subcutaneous injection that's meant to be self-administered. And that's also a good model in case lenacapavir is something that becomes available in the future, and gives us a little bit of a sneak peek, kind of proof of concept for that, if that becomes available in the future. So we also tried to make this, again, simple and fun for, I don't know if this is really fun, but as fun as it could be for our young women using these different products. So this is just one example of how they could use the OraQuick HIV self-test in, a pictorial form, easy to follow. This is in Swahili, so I don't know how many of you are Swahili speakers. I am not one. But I think this is just a nice example of making this more relatable and easy to use. This is just another example from PrEP. So inside the package, there's, this is what it looks like, and they have some really easy to use instruction cards. We did include all of the official instructional package just for medical legal reasons, but we know that most people don't read those sort of things. So this really highlighted the key elements that we thought were critical for them to know. Okay, so I hope this comes through. I'm going to play a video. We had several that went along with every component of the kit. So let me know if this is not working.
Jessica, I think you need to share the audio if there is an audio.
Okay. So I don't see how to share audio. You can't hear it?
There's the little caret that's by your video, where you turn your video on. There's a video settings.
Peer or your healthcare worker to keep you HIV negative.
Okay.
And after an assessment of other conditions to make sure it is safe for you to use. One good thing about PrEP is that you can take it with or without food. And since it doesn't become effective immediately, make sure you take PrEP once a day for 1 week ahead for effective protection. Do not stop using condoms during this period because they will offer you the best protection from HIV before PrEP starts working.
Okay, that seems to have stopped a little early, but I think you get the idea. And this was, made a few years ago, so we might tweak things a little bit now. But this kind of approach is what our young women in our focus groups and so forth said they wanted. It was a little, honestly, different than I thought they would, how they would like to receive this information. But the whole purpose around our intervention is my way or their way of getting the information. Oops. Okay, so let me move on. So now I'm going to kind of switch gears a little bit to tell you more about what we actually did to see if this works. It's a nice idea. People seem to like it, but does it actually help with that, persistence for PrEP? So we did a randomized trial with 150 women. They were randomized 1-to-1 to My Way. Oh, and I forgot to tell you, we kept calling it PrEP My Way because we thought that would be a great name for it. But our clients wanted it to be called just My Way. So we got rid of the PrEP at the beginning, but old habits are hard to break. So we're trying to stick with just My Way because that's what they wanted. So we randomized women 1-to-1 to My Way versus standard of care, and we followed them for 6 months. So this is a relatively small trial, proof of concept with, it's an R34 from NIH. So many thanks to the NIH for supporting this work. But this type of trial is really designed as a proof of concept. So we wanted to know about the feasibility of, bringing these into the community. Did people use them? Acceptability, how did they think about it? And we did that in a mixed methods approach. And then we looked at preliminary impact. So I can't say that this is definitive based on our sample size, but we wanted to look at, again, did we improve how each of these components were used in the kit compared to going to clinic? And then ultimately how much PrEP was used in this population. And we explored some influencing factors, potential mediating factors that could explain whatever results we came up with. So this was recently published in JIS, but I'll go through the major results now. So our participants, they were all young women, and we did push the age down to 16. We initially were working with 18 to 24, but we know that younger women need these kind of services and may actually be the most reticent to come in. I can say, honestly, it's hard to recruit this population, but we were able to get a few who are 16, 17 years old. They were all sexually active. They were initiating PrEP in a couple of different clinics in the Kisumu area. And you can see the map here where Kisumu is in Kenya. And they all had to have phones because they needed to speak with the peers. And our team is fabulously talented in all the languages you see here, in Swahili, Duolingo, and English. So they had to speak one of those languages. And then we had very minimal exclusion criteria. So our study procedures. So again, people were initiating in 2 clinics, either Lumumba or Kisumu County Hospital, for those of you who know the area. We administered some baseline study type stuff, and then we tried to replicate what this would look like if we were going to deliver it, in reality. So the peers offered delivery at month 1, 3, and 6, and then we had them come back in to collect DBS and do an exit questionnaire and interview. And those who were in the control were just encouraged to follow up either at Lumumba or KCH or wherever they chose to get their care on a similar schedule. This is following how those clinics typically provide PrEP and other sexual health services. And then again, bringing people back at 6 months. So we ended up screening 154 women and enrolling 150. So this is a very easy to enroll study. The women were very interested in participating. There were only 4 who we had to exclude for the eligibility criteria. We randomized them 75 and 75, and we lost 4 in each arm. So just to give you a brief idea of who was in the study, not surprisingly, their median age was in the early 20s. And I would say that our randomization worked pretty well. Things are pretty similar between the My Way group and the standard of care group. Reasonably well educated, about half were students. Most were single, and we did distinguish between study partner and not study partner, and perhaps a few more in the standard of care did not have a study partner. We actually anticipated people being a little bit further away from clinic and finding it more difficult to come in, and there were not as many of those, which I'll come back to in a minute. Our population, as I said, was pretty well educated, which is just reflecting the area where we were running the study. And there was a mixture of urban, semi-urban, and rural. So looking at some baseline factors that may have some particular relevance for PrEP use, adherence or persistence. We looked at the number of current sexual partners, and this is just a summary. We went into a lot more detail than this, but on average, it was about 2, 1 main and 1 casual for most of the women in our study. Very few had a known history of an STI, and we can come back to that as well. The satisfaction with clinic was actually relatively high. We anticipated some concern about stigma. Again, that was part of the whole purpose of this intervention, is to overcome concern about coming into clinic. So that satisfaction was a little bit higher than we thought it would be. And again, finding time to come into clinic, I think I replicated that one from the other slide, was actually not as hard as we thought it would be. Alcohol use was present, but not overwhelming. But we were a little surprised, and I think it's quite important to see how high levels of depression were. This was with the PHQ-9 that has been validated for use in Western Kenya. We found sexual relationship power to be reasonably high, but also stigma was quite high. And I won't go into it today just for sake of time, but we've done some additional, like a deeper dive into stigma, which I think is really important to consider, perhaps for modification or other interventions going forward. And about half of them felt a high need for PrEP. So our main findings, so looking at feasibility, again, this was one of the major goals of our project, was basically, how well could we get these components to our participants? So I'll just break down this figure here. On the y-axis, we've got the number of participants, and on the x-axis, we have each arm of the study. And then the purple reflects whether or not they received PrEP. We'll talk about actual use in a bit, but just ability to receive PrEP either from the peers or through the clinic if they wanted to come back in. Pink is looking at any STI testing done. And the blue is hormonal contraception. Again, we also handed out lots and lots of condoms, but this is focused on women who chose to get hormonal contraception through our kit. And I will say that about 10 to 14 women in each arm had either an injectable, or I'm sorry, an IUD or or an implant. And so that would not have been a relevant, service for them because they already had long-acting contraception. But what you can see here is at month 1, month 3, and month 6, there's a lot more activity in the PrEP My Way arm compared to standard of care. So if we break it down a little bit more, looking at PrEP received, so we had nearly all of the 75 women who were in this study arm received PrEP at month 1. It dropped a little bit over time, so down to about 60 at month 3 and 50 at month 6. And this may, again, reflect women who decided that PrEP was no longer for them. But when we compare that to these diagonal lines here in the same color, so again, purple reflects PrEP use, or receipt, I should say. There's a dramatic difference here between close to 70 and up close to 30 and the standard of care. And again, we see the drop off over time, but much lower in the standard of care. When looking at how much STI testing was done, almost all of the women chose to have STI testing at month 1, month 3, and just a very slight drop off at month 6. So we can see the STI testing was very popular. And we did actually find quite a bit of gonorrhea and chlamydia in this study. Looking at hormonal contraception, that was pretty steady. It actually went up a little bit in month 3 and came back down. And then comparing that to the standard of care, there was 0 STI testing done in the standard of care arm because that is syndromically managed typically, although the clinics did reassure us that if somebody asked for STI testing, they would do it. But that's not anything that we saw in our study, and very few women continue to get hormonal contraception. So in terms of acceptability, 88% preferred My Way to clinical care. 91% said that they would use it in the next 12 months if it were offered to them after the study concluded. And 92% found peers to be either acceptable or very acceptable for delivering these kinds of services. We use the median systems, we use the systems usability scale, which is kind of an overall look at how well an intervention is received kind of holistically. It's a validated scale in many different settings, not specifically this one, but it's widely used. And that was 76, which is really considered excellent performance. And then we asked of the people using each of the different components in the kit, whether it's the videos, the actual test itself, the delivery system, 95 to 99% found them either acceptable or very acceptable. So looking at persistence at 6 months, and we would have loved to do this at month 1, month 3, and month 6, but we did not have enough funding to do that. Here you can see one of our peers getting on a boda to deliver one of the kits. But you can see that at 6 months in the My Way arm, if we look at just all of the women who were enrolled in sort of an intention to treat approach, we had 16 who had detectable tenofovir at 6 months. And in the standard of care, there were 4. So that's a difference of 16 to 5, which is statistically significant. If we look at prevention effective persistence, and by that, I mean, we limited the denominator to those who either self-reported PrEP use, meaning that they wanted to be taking it. It had more than one partner, which we found in IMPIA and other studies as an indication that PrEP use may be needed. Reporting condomless sex or reporting a lot of concern about getting HIV, we thought that was defining a group for whom PrEP still might be a good option. There's no consensus on exactly how to think about that, but that seemed like a reasonable approach. So that decreased our denominator a little bit. And so that changed our comparison from 16 versus 5 to 18 versus 7, which went just above the threshold for statistical significance, but a similar pattern. And with this type of study, this is roughly what we felt like we would be powered to do. Interestingly, when looking at the median levels of tenofovir diphosphate in these dry blood spots, the My Way intervention had a lower amount. So the initial comparison up here is just for detectable tenofovir. The overall levels were fairly low within our group. We're not entirely sure why that is. If they were not taking that much, maybe they were taking it when they needed it and not all the time. There may also be some, metabolism that needs to be factored in here. But the few that were taking it in the standard of care, I think we're taking more of it, which is, I think, important to think about as well. Perhaps being a very highly motivated group to be able to come into clinic to get these services, and maybe, you know, perhaps different than those who were getting it brought to them. So as I mentioned earlier, we did look at some of the factors from those baseline characteristics to see if we could predict who would have the detectable tenofovir at 6 months. And the only thing that we were able to find statistical significance for was being in the intervention arm. So 3.5 odds higher of having detectable tenofovir. I did note here that moderate or severe depression was a near significant. You know, again, this is not a hugely powered study, so I can't say that it was you know, a true finding, but a suggestion that depression may be something we need to be paying more attention to. But I just highlighted here, given that over half of our women reported depression at the beginning, which again was unexpected for us. I list here all of the other things that we looked at, but did not find significance in our analysis. And then the final result I want to just share is that we did have 4 pregnancies in each study arm. So lots of contraception use, perhaps not enough, because I'm not sure that most of these were desired pregnancies, although some may have been. And fortunately, nobody tested positive for HIV in our trial. So I will conclude by saying that PrEP My Way, or My Way, is a novel PrEP delivery system with high feasibility and acceptability. We think it's very promising for delivery of PrEP and other sexual health services to a population that has had suboptimal engagement in traditional health systems. The impact on persistence, I think, may be enhanced through alternative PrEP formulations. You know, we've essentially created a really desirable and I think feasible delivery system. But for some of those barriers of overcoming the daily PrEP use may not be addressed by what we developed. Although having further support, you know, maybe some additional support and perhaps treatment for depression could help more with overcoming some of the other barriers. But making the PrEP easier through longer acting formulations like the vaginal ring or injectable cabotegravir, or ultimately lenacapavir, may help kind of marry this solution for some of the problems, like the delivery system and engaging with a young population over time, versus some of the challenges of actually taking PrEP. In future research, we hope we'll explore scalability of this model in routine care and including those formulations. And I will say that we are hopeful that we'll be starting an R01 soon, which is a much larger study to look at PrEP My Way in combination with these other formulas and with some of those enhancements that I described, drawing a lot from the REACH 034 study, which showed how much formulations can really help in terms of adherence and ongoing persistence, and also providing a menu of different adherence support options that I think could be delivered through the peers. So the last thing I'll do before opening this up for discussion is I just want to mention some additional analyses that are coming out of the PrEP My Way study. So this is a very recent photo. If any of you were at the IPAC conference just a week or so ago, this is Lawrence Juma, who's one of our clinicians. He gave a nice oral presentation looking at differences in people who received PrEP versus had detectable levels. Which I think, again, I don't have time to go into all of the interesting findings that came out of this work. But the bottom line was it was actually pretty difficult to distinguish. And I think there's a lot we need to learn about when people are using PrEP and why. And that's something that we hope we can do if we move forward with this R01, because we'll have the ability to measure objective use of PrEP at every time point in the study, not just at one like we had to in this pilot. We had another poster looking in detail at how women chose to use different types of contraception from Melvin Kitch. And then a couple other presentations. Bernard Nayeri from our group was selected for a poster at CROI looking at the stigma issue I mentioned very briefly. He unfortunately could not get a visa, and I should also mention that Melvin could not get a visa either to come to these meetings. I'm sure all of you have similar frustrations around the visa situation and engaging our partners in these kinds of academic discussions at meetings. That's unfortunate, but it's great to see that their work was at least acknowledged. Vincent Momanyi is going to be presenting our work in more detail on the STI piece at the International Meeting on STIs in Australia coming up. And again, Bernard is hopeful he'll get a visa this time to present more about preferences for formulations from our study at R4P. And Alfred Odira is presenting our qualitative work. I mentioned we did some mixed methods work on acceptability and trying to understand the difference between receipt and use, which he will hopefully be able to present at R4P. They've both been invited, but we're just hopeful on the visa situation. So with that, I will conclude. Just want to thank all of the participants that made this work possible. An absolutely outstanding team I've had the honor and privilege to work with for almost a decade now in Kisumu. Particularly highlighting Professor Bokusi, who has been my partner for many years, along with Aaron Siegler and Jared Baton. Funding came from NIH, as I mentioned. You can see my email address there. And just to highlight our team here, this photo here is from a community dissemination meeting we had about a year and a half ago, really engaging with the Ministry of Health at the local, regional, and national level so that we can hopefully include this work in the national program. And NASCOP, which is the National AIDS and STD program, is very involved in what we're planning going forward. And I just wanted to highlight how we managed to do all of this during the pandemic. You can see all of our masks on as we started the trial, I think really pretty much during the height of COVID. So I will stop with that, and I hope we have a few minutes for discussion.
Wow, thank you so much, Jessica. That was amazing. Gosh. Thank you so much, and lots of applause all around for you. I actually have a list of questions to ask because they're so exciting and interesting, and I just want to invite everyone in the audience to also please share your questions in the chat, or if you want to raise your hand, your virtual hand. And so maybe just to start off with, wow, I'm just first of all wondering if you also maybe as next steps have any thoughts on any qualitative exit interviews, or if that has already been done. I just kept wondering about like certain things like sources of PrEP stigma or various things that were coming up throughout the trial. And I'm just wondering if that may also be part of next steps.
Yeah, I mean, in terms of next steps, we're very hopeful that this R01 funding will come through so that we are able to go into much more depth than what we were able to do in the pilot trial. And I think we're looking forward to multiple levels of understanding what this could look like in practice. So one is from, oops, I'm getting a pop-up here. One is from the perspective of implementation. So what we've proposed is a type 1 hybrid design so that we can see like how light can we make this, so that implementation is likely to go forward. Especially if we're thinking about giving injectables in the community. And that would require at least some level of nursing training, which would change the model. So that's one thing we need to explore. But also what would it look like with the vaginal ring? What would our peers feel comfortable doing? How can we think about those tensions between making things easy and accessible and familiar in the community with some of those slightly more medical kinds of components? From a qualitative perspective, we are just kind of still digging through. As I think you all know, qualitative work is time consuming, to say the least. But I think, absolutely critical to get that experience. As I was hopefully conveying to you at the beginning, this process has just been absolutely delightful to really engage with our clients and hear their preferences and, getting that full rich acceptability data. And I think Jen Velosa's on, or she was, and we've talked about the difference between acceptability and desirability, and we want to make sure that what we're providing is not just acceptable, but really desirable and what people want. So yes, definitely a lot more to come with the qualitative, and to understand that prevention effective piece in practice. And then, just also to understand like what kinds of supports are we lacking? The stigma, and I, again, didn't get into it from for sake of time, but we actually found an increase in stigma over time in our population. And I've talked to Erin Siegler, who has seen this in other settings as well. So really trying to unpack that and understand why that may be the case, and is there something we can do about that with our delivery models? And thinking again how to do that in routine care as we get into like a less controlled setting where it's, that role of the peer is so critical. But as you roll out into broader settings, you may not have as much time or control over selection of peers, and how do we train them in a way that is going to balance all of that. So a lot to learn, and definitely more to come in that area.
For sure. And there's a message from Nafisa. I think Nafisa may have dropped off the call, but I'll just read the question. So this is awesome. And Kenyan research teams are really paving the way for intervention, pairing HIV self-testing with differentiated PrEP delivery. So she had two questions. Was there any PrEP continuation counseling follow-up or /follow-up between study visits / kit drop-offs? I know you had mentioned some peer side effect counseling. If so, when and how was that done?
Yeah, so the peers were encouraged to communicate with their clients in whatever made sense. Again, this is called My Way because it's meant to be the way of the participant, not necessarily prescribed by us. So everybody had phones, and they either communicated through WhatsApp, through calls, et cetera. And so we had an initial training, we kind of codified it, so it's something that could be replicable. And whenever the peers felt that the questions went beyond their expertise, we had a clinician, Lawrence was the primary clinician, and he would take over. If something, like if anyone had a positive gonorrhea test or chlamydia test, they needed to come back in and get the official counseling, that sort of thing, to satisfy regulatory requirements, because we do need to pay attention to that and make sure that we're in compliance with what's expected locally. But there was a lot of encouragement for, questions, support, et cetera, kind of on their own terms. And in the R01 that we, again, are hoping to start soon, we're trying to codify that so that it is scalable, and see if people want WhatsApp groups. Do they want to have one-on-ones? Do they want to have calls? What would that look like? How could you protocolize that for something, that could be implementable in the MOH setting?
Gotcha. And I think you already answered the second question, but I'll just read it in case there's anything else.
Okay.
She says, did you conduct any qualitative interviews with clients who received My Way, but had low tenofovir or TFV on DBS to understand their experience on PrEP? Perhaps this was part of the IPAC oral presentation. Yeah, so we haven't gotten into enough of the qualitative. That's what Alfred is going to be presenting at, hopefully at R4P. So if you're attending R4P, he will be there. Or at least I hope so. Yeah, so a lot of the barriers that we saw were some of the typical ones that you've seen in the past, that it's just hard to take a pill every day. I think our intervention can do a lot. It can't do everything, which is why we're hoping for those people that the different formulations will make a difference. But I think this piece about depression is something that we also need to pay a lot of attention to. And, how much can we do with an intervention? That's tough, like in some ways that's a philosophical question of what is our mandate? What are we able to do? What can we do in the context practically? Especially if we're trying to make something that is sustainable and scalable within the MOH system. But perhaps through referrals and linkages to other existing services, we can overcome some of those additional barriers. Thank you, Jessica. And Jason, I see your hand raised if you want to come off mute.
Sure. Hi, Jessica. Thank you for a very, very interesting discussion. I work with the Search Consortium of Studies, so also with Elizabeth. And much of what you said has lined up with our dynamic choice prevention study as well. In your presentation, 3 elements stood out to me. I have so many more questions, so I might follow up via email afterwards. Please do. The first one was in your avatar persona
Mhm.
slide, you noted that Alice was the key decision maker. And then you mentioned you had also brought in the partners or spouses. One of the things we've found as well, and of course, our studies are on the other side of the Gulf in Homa Bay County, is
Mhm.
that in-laws also often
Mhm.
have an influence, particularly in polygamous families. And I was
Mhm.
wondering if you had done any outreach to in-laws or brought them in. The second question I had was, we also noticed depression as a very significant factor among youth, and we're trying to go through our qualitative data to delve more into that. But I noticed in your slide that the intervention group seemed to have much less depression. It was still quite high at what, 50 something percent,
Mhm.
had less depression than the control group. And I'm wondering if you think enrollment in the intervention or something about the intervention might have influenced that, or was the depression scale assessed just at baseline?
Mhm.
And then the third element was with PrEP stigma. I was wondering, stigma is such a big topic, so we might
Mhm.
not have time to get into it. One of the elements we discovered was there can be stigma against using PrEP, like, oh, you just want to like have lots of lovers. But then there was also the stigma that comes from people confusing it with ART.
Mhm.
And I was wondering if that might be something you've also been able to parse out. So those are my three
Yeah.
questions.
Yeah, so just very briefly, and we're definitely happy to talk more later. So for the in-laws, we did not get into that. We just followed the cues from the people in our groups, and didn't come up as someone who was critical to bring into the design. But I see what your concern is. I think one of the nice things about My Way is that people can receive it, and they did receive it in lots of places. Some quite surprising, like where people wanted to get this kit. We were imagining mostly at home, maybe at work, but some of the work environments, like bars and things, were where people wanted to get their services. So it's their way, and that's where we delivered it. So I think in those really complex dynamics, they may just choose to get their services away from home if that's possible. But it's a good point and something we can certainly think about, because we are with the R01 that we're hoping to start soon. We have another design phase where we're going to be bringing in some of these things I've brought up, like the different formulations, how to think about the adherence support. So the in-law environment is something we can certainly add to that. In terms of the depression, I don't know like if it's statistically different between the two arms, but this was just a baseline measurement, and I think our takeaway was that it's an issue, for sure, that I think we didn't appreciate enough, and we'll need to also include going forward. And then I think the last question about stigma, it is so complex. If you, I can send it to you later, but the poster that Bernard Nayeri prepared for CROI goes into this in a lot more detail. We looked at multiple different stigma measurements. Again, drawing a lot from Aaron Ziegler's work, because he's gone into quite some depth with different elements of stigma. And it was just all over the map, people feeling proud for using PrEP, but also feeling shamed by using PrEP. And these are the same people, who are reporting such a mixture of pride and shame, which is, it's so unfortunate that those feelings have to be so strong, but they were, that people really, I think, struggle with the concept of PrEP in so many different ways. And I'm not honestly sure what to do about that, and I think there's a lot of thinking, and I would love, if other people have contributions of like, how do we address that? Some of that is culture change, some of that may be comfort over time. What can we do from a peer perspective to support people as they're struggling with that? But I think even just the recognition of that mixture, it's not just somebody who has no stigma and somebody who has lots of stigma. It's really just, so complicated. And I think there are, a myriad of influences, from religion to, culture to education. So other than to say like the classic more research is needed. I'm not sure, what we can say at this moment, but it's something that we're definitely thinking through as we hope to expand this work.
Excellent.
Thanks,
Wonderful.
Jessica.
Thank you.
Jessica, so two more questions. One is from
Yeah.
Anna. She's asking, did you experience any form of contamination? For example, participants crossing from standard of care to the intervention arm?
Yeah, so we were on the lookout for that because this was an individually randomized study, and we did not really see anything like that. The intervention really starts after they leave clinic. So unless somebody discloses to somebody else that they are in the intervention arm, it's not otherwise visible. We do recognize that young women tend to come in packs, for lack of a better term. They're a very social group. So it is possible, and it's something we're going to have to keep an eye on because we are planning to do individual randomization going forward, hopefully in 4 different settings where we can get an understanding of what is it like to be in a dense urban environment, what's it like to be in a much more rural environment. As I said, we did not have as much difficulty in the way of like transportation or clinic dissatisfaction that we were anticipating. So it may be that in other settings we actually see more of an effect because if those are relevant factors. But in terms of the question specifically about contamination, we didn't see any, but it is conceivable that people could just be taking PrEP. That PrEP receipt was a lot higher than the PrEP use and then handing it out. Part of me is totally fine with that because I think PrEP is safe and more women should be taking it however they want. But we do need to pay attention to that, obviously, for scientific reasons, and just to think about, how can we optimize use for each of the different components for the women who want them. And I see we're at the top of the hour, so I will stop there.
And my last question was just how we can, if there's other things that our group or folks watching this in the future can reach out to you for involvement in your project. It sounds like stigma and depression are 2 things that may be possibilities, but
yeah, absolutely. We have so much data, and our team, as I hope I conveyed to you, our team is really diving into so many different elements, and there are lots of opportunities for shared exploration, I think. So if anyone is interested in thinking through this further, please feel free to reach out, and we can talk more and think about ways to integrate you with our team.
Thank you again so much, Jessica. I really appreciate it. Thank you, everyone, for joining.
Take care, everybody. Thank you.
Thanks, everyone. Take care.